this is Dr. K from the medical school, and today we're going to talk about acute pancreatitis. We're going to begin to talk about what is pancreatitis, and then go on to talk about the diagnosis and treatment. So, what is pancreatitis? Pancreatitis is an acute inflammation of the pancreas. The extent of inflammation ranges from mild disease to a severe necrotizing form. It is important to obtain a good history and physical, as to know the specific risk factors that places your patient at risk for pancreatitis. Now let's talk about the signs and symptoms of pancreatitis. Pancreatitis often presents with a mild to severe epigastric or upper abdominal pain that radiates to either side of the patient and or to the patient's back. Common aggravating factors include binge drinking or eating heavy meals. Other signs and symptoms include tachycardia, an elevated white count, hypotension, nausea and vomiting, chills, jaundice, otherwise known as yellowing of the skin, abdominal distension. More severe signs include Cullen's sign, which is ecchymoses seen around the umbilicus, as well as Gray-Turner sign, which is ecchymoses or bruising seen on the flanks of a patient. This could indicate hemorrhagic pancreatitis and needs urgent intervention. The next step is to diagnose acute pancreatitis. In order to diagnose acute pancreatitis, we have to understand what the labs mean. Amylase and lipase are the most common screening tests for acute pancreatitis. Usually we define an amylase greater than 3 times or more than normal as suggestive of pancreatitis. It's important to note that amylase is a non-specific marker, meaning that other diseases can cause elevations of amylase. Other causes of elevated amylase include diseases that affect the uterus, GI tract, as well as the bones. Note, amylase is a short-lived marker and generally remains elevated only for 48 to 72 hours in the presence of pancreatitis. Now, let's look at another marker called lipase. Lipase is a more specific marker for acute pancreatitis. An elevation of lipase greater than 3 times its normal is suggestive of acute pancreatitis. Usually a lipase elevation will last about 7 to 14 days, so an elevation of lipase lasts longer than amylase. Generally, serum amylase tends to be higher in gallstone pancreatitis, while serum lipase tends to be higher in alcohol-associated pancreatitis, though both these findings are neither specific nor sensitive. A third marker is called trypsin. Trypsin is commonly elevated in acute pancreatitis and has a better likelihood ratio for detecting pancreatitis than the amylase level. Unfortunately, serum trypsin is not available everywhere. Thus, usually lipase and amylase are our initial screening tests that we do to find acute pancreatitis. Other tests that need to be ordered include an hepatic function panel, a CBC, and a chemistry. You want to make sure that there is no hepatic dysfunction, or that there is no gallstone blocking the common bile duct leading to pancreatitis. You'll note this by elevated liver enzymes on the hepatic function panel. An elevated white count may suggest the patient also has an infection as opposed just to acute inflammation. Understanding the causes of acute pancreatitis is important because the number one cause of acute pancreatitis is gallstones, followed by alcohol. If a gallstone is the cause of pancreatitis, an ERCP may be needed. Alternate causes include pancreatic cancer, abdominal surgery, medications like hydrochlorothiazides, cystic fibrosis, ERCPs and other procedures, high calcium levels, hyperparathyroidism, elevated triglycerides, infection, and trauma to the abdomen. Now let's discuss how to diagnose autoimmune pancreatitis. Autoimmune pancreatitis is diagnosed by both imaging and serum serologies. First, you'll see on imaging diffuse narrowing of the pancreatic duct as well as an enlarged pancreas. There may be some fibrotic changes in the pancreas as well. An elevated IgG4 in the setting of a history and physical consistent with pancreatitis may suggest autoimmune pancreatitis. Anti-nuclear antibody and rheumatoid factor can at times be positive in someone who has autoimmune pancreatitis. Now, it's important to stratify patients with acute pancreatitis because acute pancreatitis can present with very mild to very severe forms. We can do this by estimating the Pancreatitis score, which estimates in-hospital mortality based on certain risk factors. These risk factors include mean blood pressure, glucose, pulse, hematocrit, urine output, PaO2, respiratory rate, albumin, bilirubin, creatinine, white count, BUN, sodium, and temperature. Using these factors, we can tell if someone is at higher risk for mortality versus lower risk of mortality. Now, let's discuss the treatment of acute pancreatitis. The most vital step in the treatment of acute pancreatitis is IV fluids. Generally, you want to place patients with acute pancreatitis on 200 cc's per hour of normal saline. The reason why is the pancreas is becoming edematous and is having difficulty supplying itself with enough nutrients. Providing volume resuscitation decreases the risk of necrotizing pancreatitis. In addition, you want to make the patient NPO, as no oral intake decreases the level of symptoms they may have. Imaging is very important in diagnosing acute pancreatitis. We usually do a CT of the abdomen, but if that is not available, an ultrasound of the abdomen may suffice. About a decade ago, patients with acute pancreatitis would automatically get NG tubes. This has shown not to benefit patients either in their symptoms or the number of days they stay at the hospital. However, if a patient has persistent nausea and abdominal pain and cannot tolerate an oral diet after 48 hours, it's important to provide them nutrition via a Dabov tube that places nutrition post the sphincter of Oddi. This has been shown to improve morbidity in patients with pancreatitis. Other considerations include obtaining a GI consult for an ERCP or EUS, depending if the patient's pancreatitis is due to a gallstone/biliary stone versus pancreatic cancer. The addition of antibiotics to patients with acute pancreatitis has been significantly discussed in past literature. Adding antibiotics to patients with acute pancreatitis has not shown to improve morbidity or mortality, unless there's a clear infection present. If there is a clear infection present, then imipenem has shown to be of great benefit to patients with pancreatitis in the setting of infection. We've just reviewed what is acute pancreatitis, its diagnosis, as well as the treatment of acute pancreatitis. If you've liked this video, please give it a like, comment, and subscribe. Also, you can download these lectures on iTunes by just searching for MedPulse. In addition, you can take a look at these lectures and other articles at www.medpulse.org. This is Dr. K from iMedical School, and I'll see you next time.